Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good afternoon. I'm Dr. John Langell, the president of Northeast Ohio Medical University, and it is my pleasure to welcome you to VITALS. VITALS is an open forum to discuss our nation's biggest healthcare problems and to hear from leaders that are using the VITALS tools to solve these problems at a local and a national level. VITALS stands for value, innovation, technology, advocacy, leadership, and service. Today, I'm excited to bring to you our speaker, Dr. Kendalle Cobb. Dr. Cobb graduated from Harvard University with a bachelor's in history and earned her medical degree from George Washington University. She completed her family medicine residency at Kaiser Foundation Hospital in Fontana, California, and an academic family medicine fellowship at Boston University. She practices at the Cleveland Clinic and serves as a clinical associate professor of family medicine at the Cleveland Clinic Lerner College of Medicine, where she has also served as the director of diversity and inclusion for 10 years. In 2021, Dr. Cobb was appointed Associate Chief of Staff of the Cleveland Clinic, where she focuses on recruitment and retention of physicians with a specific focus on those traditionally underrepresented in medicine. Dr. Cobb also serves as Diversity, Inclusion, and Racial Equity Council. Her responsibilities include helping the enterprise to measure patient health disparities. Dr. Cobb is a nationally regarded speaker and panelist on several topics, including NEOMED's anti-racism workshop, The Physician-Patient Perspective. Please join me in welcoming Dr. Cobb as she shares her insight on health equity. Dr. Cobb, the floor is yours.
Thank you, President Langell. Thank you for having me here today, and thank you all for joining during your lunchtime. I'm hoping that over the next few minutes, you'll be able to understand what health equity is, to identify steps to achieve health equity, and to recognize that we each create the culture of an organization to ensure health equity. I want to share with you what's going on here in Cleveland and Northeast Ohio. Right around the hospital, life expectancy is 23 years shorter than it is just 4 miles away. That's huge, and there's something that we can do about it. Health equity means that everyone has a fair and just opportunity to achieve health. Our ideal state at the Cleveland Clinic for patient care is to have culturally aligned, equitable, and inclusive care. I want to share with you a little bit about what the American Hospital Association says that any organization can do to journey towards health equity, and then share with you a few of the things that we're doing here at Cleveland Clinic. The first is culturally appropriate healthcare. I'm going to mention the 6, and then I'll go a little bit into each of them. Equitable and inclusive organizational policies, collection and use of data to drive action, diverse representation in leadership and governance, community collaboration for solutions, and lastly, systemic and shared accountability. So there are a few things that are important. One can imagine that if you have a patient that is very different than you are, has had different life expectancies, different life experiences, then you might think, excuse me, you might think that you can just treat them how you treat everybody. There's something called the platinum rule, which is to treat others as they wish to be treated. And so you have to modify your approach to patients based on what their needs are. I've recently had patients who had avoided getting healthcare for decades because of how they were treated when they went to the doctor's office. These are patients that struggle with obesity, and they felt shamed and not treated with respect. It's also important to be aware, as we're taking care of people from different backgrounds, if they have certain religious beliefs or are observing a practice that would be something that would affect their care. For example, if a patient were hospitalized and they were Muslim and it was during Ramadan, it would be important to know that they're fasting during daylight hours. And so part of what is important is to make sure that we're aware of the differences and honoring the differences between people. The next step is policies. One of the things that I was talking about with Monica Robbins before this call was policies and the impact. So one of the things that we focused on in the last 2 years here at Cleveland Clinic is really looking at policies, not from like what they were initially intended for, but what is the impact and the outcomes of our institutional policies. For example, I was learning earlier today about someone who had been hired for environmental services. We used to have a rule that someone has to be in their position for a year before they can apply for a transition. Well, then they found out that this was somebody that had majored in chemistry who was planning on applying to nursing school. And so through a series of conversations, they were able to move him to be a nurse's aide, which was much more fulfilling for him. So we have to make sure that we recognize how policies can adversely affect people and not be so focused on policy that we neglect enhancing and nurturing people to their full potential. Another thing that we focused on in recent years is switching from a list of certain criteria that have to do with graduation requirements and that kind of thing, and really focusing more on skilled-based assessments and hiring, and also creating career paths for people. So if they enter at one level, they have a trajectory of moves that they can make within the organization. The thing that I'm most passionate about is the work that I've been engaged with in the past year, which is helping the organization to develop a health disparity measurement. Cleveland Clinic is a world-renowned organization. One of our motto is that every life deserves world-class care. But we know that unless you look at outcomes, unless you measure something, you're not going to be able to move it. And so in addition to overall outcomes, one of the things that we're looking at is all of the different factors of a person that can impact their health. And so some of those things are race, ethnicity, language, sexual orientation, gender identity, but it can also be things like disability or military status, social determinants of health, area deprivation index, and immigration status. And so we're looking at how we perform as far as outcomes and experiences based on how patients identify. Part of that also has to do with making sure that we have the information from patients. So that means helping patients to understand why we're asking the questions, but also giving employees, what we call caregivers here, the language to sensitively and respectfully ask patients about how they identify, and making sure that the right member of the team is asking the question. One can imagine that you don't necessarily want somebody asking at the front desk what somebody's sexual orientation is. That might not be the right member of the team to ask that question. The next thing is diversity and diverse representation in leadership and governance. So 9% of our clinical institute chiefs are women. That is in spite of the fact that 40% of the doctors that work at Cleveland Clinic are women. So we have a ways to go with that. But we also have 27.3% of our institute chiefs. So these are the senior leaders of our clinical areas that are underrepresented minorities. As far as the people that directly report to the president and CEO, that's called the executive team, 35.7% are women and 14.3% are underrepresented in medicine. The next step that's important in achieving and journeying towards health equity is community collaborations for solutions. That is recognizing that the people with the lived experience have the expertise to know what is going to be most helpful to them. We have a few of those. Langston Hughes is an area resource center that now has a gym where we have exercise physiologists to give feedback to people, and it's a safe place where members of the community, regardless of whether they get their care at Cleveland Clinic, can go and exercise and have a safe place to be fit. El Centro is an area on the west side that we've partnered with to provide care to patients who primarily speak Spanish. We're engaging more with community health workers. That is, people from the community who are trusted and well-known to help patients achieve their health goals. There's something called Unite Us. So we ask about social determinants of health, asking if people have transportation issues, housing issues, but then what do we do with that? And so there's a platform called Unite Us that we enter that information into, and then that organization, which is used by other healthcare systems in the city, is able to connect patients with community resources and to track whether or not they actually followed up with that. We also automatically do referrals to social workers in those cases, or if somebody is having an issue with intimate partner violence, escalating that to protective services, which is our police force. And then a huge problem in the United States, and specifically in Northeast Ohio, is infant and maternal mortality that is disparate based on race. And so we partner with Birthing Beautiful Communities, which is an organization that has doulas that accompany patients to their appointments to advocate for them. And lastly, systemic and shared accountability is key. That is, everyone is welcome here, but not all behavior is welcome here. And making sure that we have a just culture. That is, are we having reasonable expectations? Do we help people to correct their behavior if they have a problem? But also that we have certain standards that people should adhere to keep patients and other caregivers safe. And we are moving towards being a high reliability organization. That it means speaking up if you see something wrong, doing something if you see something, doing something and saying something if you see something. And so lastly, I just want to say that acting on that principle of everyone deserves world-class care is something that is essential to becoming a health equity home for everybody. That is, that we can't just act like, oh, people are lucky to be here. People choose to entrust us with their care. People choose to work here. And so really valuing that choice, honoring that choice, and expressing appreciation. Speaking up when we see something that isn't right. If we see somebody that hasn't been treated well, if we see something that is going to adversely affect them or their health, saying something. And then lastly, recognizing that we don't know other people's journey. And so it's important to approach patients and each other with humility and also with respect. And with that, I'm a little bit short, but that leaves plenty of time for questions. I'm going to turn it over to our question and answer moderator, Monica Robbins, who's the WKYC Senior Health Correspondent.
Thank you so much, Dr. Cobb. I want to welcome all of our Zoom participants. We have 65 of you on this program today. So in the Q&A, if you have any questions for Dr. Cobb, please put them in the Q&A and I will get to them. But first, Dr. Cobb, I'm very glad you brought up Unite Us, because you and I were talking about some of those programs prior to, and you mentioned that the clinic does screen people for those social determinants of health. And then you work with Unite Us to make sure they get to a partner organization. So my question is, what if they don't follow up? What happens then?
Yeah, so there are two parts of that. One is that we ask people if they're interested in getting help for whatever it is. Unite Us lets us know if they didn't follow up. So that's a key piece that we didn't have before. A lot of times we'll put in referrals for things and patients don't follow up. We don't know about it. So that's fed back to the clinician. The second thing is that social determinants of health, there are a lot of questions that we currently ask when we're screening. And that can be a barrier to people. And so really streamlining the questions that we ask, and also making sure that we're making them available to everybody. Currently, in the past few years, the default has been using MyChart, which is electronic health record. But you can imagine that that would exclude many people that might have social needs that might not have access to MyChart.
Our questions are starting to come in. So the first one, this is a tough one, is achieving health equity even possible?
So that's what I love about the American Hospital Association. It's the journey to health equity. I think that it's sort of like excellence or perfection. I don't know that we'll ever get there, but there are certain things that we can do to move closer, and we have to be intentional about taking steps, because the default is maintaining the systems that we've had.
Marguerite wants to know, Cleveland Clinic sits in the middle of an area that has poor health outcomes. What percentage of the surrounding neighborhoods actually use Cleveland Clinic for their primary health?
Yeah, so I think that that is a huge issue, partly because for a long time, for probably the first 70 years of our existence, we didn't have an emergency department. That was intentional. And so part of what we are working towards is recognizing that Cleveland Clinic is a place for a person like me, whoever that person is, and really building that trust. And I think that our Chief Community Officer, Vicki Eden Johnson, through the work with Langston Hughes and other organizations, really helping people to know that they can trust us, that we're partnering with them, that we're not trying to take over their space or things, but people have to feel like they are welcome here, that they're going to be treated with respect, and that they're going to get world-class care. And so that's why it's so important for all of us to really shift our perspective to recognizing that people have, lots of choices of where to get their care in Northeast Ohio, and really making sure that people feel like this is someplace where they'll be treated well and that they'll get excellent care.
Next question, with Cleveland being such a prominent part of the clinic's name, how does the institution's brand stay so well respected with the health of Cleveland and Ohio being among the worst?
That's a great question. I think part of it is that when people have something really bad going on with them, they know that they can come to Cleveland Clinic and get excellent care, innovative care, that they're going to be put first. So I think that that's part of it. I think that traditionally the healthcare system has focused writ large nationally, has focused on subspecialty care. And I think that in the last few years, we've been moving more towards population health, which is not focusing only on the people that come into our offices, but who are the people that, might consider me to be their doctor, but haven't come in several years. And then what is our outreach to them to maximize and optimize their health? And so I do think it's a shift. But I think that that's part of the discrepancy too, is sort of this subspecialty, I want to go there if I have something catastrophic, but then also making sure that this is someplace where people feel like they can get their day-to-day care.
This might be a difficult question for you to answer, but I'm going to throw it out anyway, because it's connected to the previous question. So do you have any idea, Cleveland Clinic has so many facilities across the country as well as around the world. Where does the US compare regarding diversity and equity at those other institutions?
At other Cleveland Clinic organizations. So I know that, for example, Abu Dhabi, their big issue is more related to gender, both patients not feeling comfortable coming in necessarily if they feel like they're not going to have a same gender physician, but also flexibility around recruitment and retention. London, I'm not sure because it's too new. Florida has more Latinx providers than Northeast Ohio does, but I think that universally there's an opportunity to have diverse leaders. I think that there are opportunities in all those spaces.
Another question: to achieve equity often demands resources at times when health equity is not a national priority. What can resource challenged institutions do to help?
Yeah, I think that, let me think about that. I think that recognizing that there are some things that don't cost money. I think that talking to people where you are about the importance of healthcare screenings, whether it's colon cancer screening, mammographies, and helping make sure that people realize that there are places where they can get those services, whether they have insurance or not. So I think that word of mouth about the importance of prevention. I think that, I'm not somebody that likes to walk outside, but I do have people that I know that I encourage to exercise and that hold me accountable for exercising. So I think that those are some of the things that we can do to improve health equity.
Brian asks, one of the things the research suggests is underrepresented patients will see providers who look like them. Does CCF have DEI hiring practices that will allow providers to look like the underrepresented patient?
Yeah, so I think that one of the challenges that I've been focusing on in the last few years in my role is oftentimes when we have a position available, it's just open to all comers, and there's not a lot of intentionality about sort of like who we place where. That means that people come to see me in Solon, from Youngstown, from Cleveland, and so being more intentional about where we place doctors. I found that patients will seek out the doctors, but I think that we have an opportunity to make sure that providers are representative of the communities that they serve. And in the meantime, making sure that every provider that works in a facility is able to be respectful and provide optimal care.
John wants to know, do medical school and residencies dedicate appropriate curricular time to the teaching of health disparities? And is it delivered in a manner that allows students and graduates to apply those skills in a meaningful way?
I think that it varies. I think that we're very fortunate at Cleveland Clinic, Lerner College of Medicine, and Case Western Reserve University that diversity, equity, and inclusion is infused throughout the curriculum and really giving an opportunity to apply those things. I also know that Ohio University, based in Cleveland and Warrensville, does a lot of work with particularly looking at redlining and the implications of that on health equity and health policy.
How do you think the Supreme Court's decision on race-based admissions will impact the already disproportionately low number of Blacks and Hispanics who are physicians?
I think that it makes it more challenging. I think that there's still intentionality that we can do as far as recruiting at certain schools. Also, life experience is something that is not outlawed through the Supreme Court ruling, but I do think that it's more challenging. I think that given the fact that you need a certain number of people in colleges and medical schools to then become physicians to represent their communities is something that it doesn't happen in isolation. And so I think that we're all pursuing creative ways to continue to work towards having diverse workforces in spite of the Supreme Court ruling.
So we just saw on the news recently, and I think we've known this has been happening for quite some time, but there's such a severe shortage of primary care doctors. And recently we just saw another institution stop its residency program for family medicine at their downtown location, although they're keeping it in the suburbs. And I was told that one of the reasons is because it's difficult to attract residents who want to work in inner city areas where the need is so great. How is Cleveland Clinic addressing this issue with residents, and what's the answer to encourage more students to go into family medicine?
I'll answer the second part first. One is that I think that education, and particularly medical education, are very expensive. And a lot of people, myself included, graduated from medical school with a lot of debt. And so I think that as long as there is a significant difference between what primary care physicians make and what subspecialists make, we'll continue to have challenges. I think that the other piece is I don't necessarily agree with the fact that it's hard to attract people to inner city programs. As far as what Cleveland Clinic is doing, there's an integrated program where students, when they matriculate to medical school, they also match to a residency, family medicine residency, either at Akron General or at Lakewood. And they're with that practice with varying responsibilities and doing community-based research during their first 3 years, and then they go into residency. And I think that having innovative ways, and also if people know that they're interested in primary care, fast tracking them is something that's helpful. So I think that scholarships, I think that loan repayment, those kinds of things can help. I also think that, primary care physicians are sort of the quarterback of the medical team, and a lot of things fall to that provider. And so I think that when you look at all of the teams and systems that are around some of the subspecialists versus what's around the primary care physician, I think that it might be challenging for people who are considering going into primary care to sort of see people that are loving what they do. I think that there's no greater honor than accompanying people on their path and helping them through the joys and challenges of life.
We just saw, some student loan debt erased for certain people. And one of the things that struck me was that for some of the people who qualified, it was if they had gone into fields that were betterment for the people. And one would think that family practice is exactly would qualify for something like that. From your perspective, because you said this impacts you, have you looked into it, or is there any way to get, I don't know who would be, Congress or whomever, to get the attention that it deserves, that maybe doctors in family practice qualify for student loan, erasing student loan?
Yeah, I think that our government relations people, and definitely the family medicine organizations, can have an impact on that. That being said, I also appreciate that, even as a family physician, I make significantly more than many people in this country. And so when you consider about the amount of debt that somebody has, whether they're ever going to be able to pay it off in their lifetime, whereas I think that I've paid mine off in 20 years or something, I think I can understand why people might think that somebody that goes into primary care doesn't need loan repayment. That being said, I think that if people don't have that weight, if I think about people that go to Cleveland Clinic Lerner College of Medicine, they're free to choose any specialty because they don't have that burden of tuition, because we have full tuition scholarships.
Here's another question from our audience, and I encourage everyone who's still with us. We haven't lost a Zoom participant, which is wonderful. Please, if you have any questions for Dr. Cobb, put them in the Q&A section. Okay, so this one says, what novel solutions to increasing health equity are available to systems, but most are unwilling or unable to put into place?
So I'm just going to go through all 6 of them. So I think that, the time and effort to train every person and how to be culturally appropriate with patients is something that not every organization is willing to do, because I think it's time. I can tell you that one of our modules that we have to do every year for compliance has to do with that culturally appropriate care. And it doesn't only cover various backgrounds, but people with obesity and things that you need to be aware of. And so I think that that's something that people are sometimes hesitant to take the time to train people. I think the other thing is that a lot of people benefit from policies as they are, but they only benefit a certain group of people. And so I think that taking that time to sort of look at, is this serving everybody? How could this be adversely affecting certain people is a huge thing. I think it's hard to measure outcomes based on different subgroups. We have enterprise analytics and they're able to do fantastic stuff, but I recognize that a lot of people don't have that. But just sort of looking at one of the things that we're doing in primary care is, how are our Black patients with hypertension and our white patients with hypertension, are there differences in how well we're managing? And I think that looking at that, whether you have like a fancy system or dashboard, is something that's helpful. And then I think that unfortunately, there's still people that feel like diversity and excellence, it's an either or, and it's not. Our diversity helps us to be better, but there's a step that's more important than diversity, which is inclusion, which is, can people bring their full selves? We did drop somebody, full selves to their work, to their place, whether it's patients or people, what we call caregivers.
Here's another question from our audience. As wearables play an increasingly important role in patient awareness of their own health, should such devices be subsidized, much like access to the internet for those who are underserved?
I think that access to technology makes a huge difference. I can tell you that it's a different process for me to notify a patient of normal lab results if they have electronic capabilities or they don't. And so I think that the more that we can make sure everybody has access to tools that are helpful, that would be beneficial to decreasing disparities.
Another question, what made you want to become a physician, and what lessons learned through your road to becoming one can you offer to future physicians?
So the first part was why medicine. Okay. So it wasn't always that I wanted to do medicine. I actually was training to be a ballet dancer. I broke my ankle. I had a great orthopedic surgeon, made a full recovery in ballet, but really was at the point I was about 15 where I had to decide whether or not to continue pursuing ballet or academics. And so at that time I wanted to be an orthopedic surgeon because it was an exciting thing to be able to fix things. But if you look back at my life, even going back to preschool, this idea of like sort of comforting a child who was crying because his mother had dropped him off, or comforting somebody whose parents were going through a divorce. That's sort of who I am, like that sort of accompaniment. And so that's one of the things I really enjoy. There's very little I can fix, but I feel like there's great value in sharing the path. As far as tips, sorry.
No, go ahead.
I really enjoyed college. You're going to be working hard for the rest of your life. Do things that you enjoy. Make and maintain strong relationships.
Great advice. All right, I have two AI questions.
Yeah.
I'm going to sort of combine them together. So one asks, is there an opportunity for using AI to assist in the pursuit of health equity? And the other question, the second part is, what role does AI have in decreasing disparity?
Yeah. So I think that AI is broad, right? And so, for example, within the electronic health record, there are reminders if somebody's due for vaccinations or health screenings. And I think that's helpful, because when you have a limited amount of time with people, you aren't necessarily thinking of everything. I also think that it's important to still have those conversations with people, right? Like, I have patients who typically haven't had a flu vaccine for quite some time. And so there's some people that might not ask them about the flu vaccine. Patients want to realize that they're known. So what I'll say is, I see that you haven't had a flu vaccine in past years. What's your decision this year? So still giving people an opportunity, because all of us change and flex. And so just because somebody made one decision before doesn't mean that they don't. So I think that reminder is helpful. I think that there also are things that point out, like, so if somebody's hemoglobin A1C is elevated, or if somebody has a body mass index above 30, then there's certain things that show up, and then it's easy to sort of address those things, but we still have to address. So I think AI helps, but there still is the human component of having those conversations with people. One of the things I'm thrilled about is a platform or upstart that just started, which is there's a software that can transcribe my conversation with a patient, and then it makes an attempt at a note. And then I go back and I edit the note, and it allows me to be more engaged with the patient. And I think the note is much more thorough, and the patient feels like I'm much more present. So I'm really excited about AI. I don't know if that person had other questions that I didn't address with that answer.
I'm curious to know, you mentioned this earlier, that, communication is key, and a lot of patients won't go back to the doctor if they were treated rudely. So, you're talking to a lot of future physicians, and some have a scientific background, and it's not the warm and fuzzies. And what is your advice to them? Because that is critical. If you talk down to a patient, or you treat a patient in a certain way, that may impact their future health, period. So what is your advice to these students on how to communicate with people who don't look like them?
Yeah. I think getting to know people and recognizing that everybody has a story, and recognizing that, I don't know if people are religious or not, but I'm religious, but there's a saying, but for the grace of God, right? So a lot of us didn't have anything to do with the circumstances into which we were born. And so having some humility about that, recognizing that we don't know what somebody else's path is like. And one of my biases is people that are late. And I remember, and this is a doctor example, I was in a leadership course, and one of the other physicians came in late, and it was a cardiothoracic surgeon. She was a woman, and I was like, she doesn't care about this, right? And what I didn't know was that she was in the operating room, and that's why she was delayed. I think that that's also true with patients, right? When my patients are late, sometimes they their car broke down, or they had to get transportation. And so recognizing that we don't know, and we all tend to make assumptions, but taking the time to just sort of be curious and to suspend judgment. People don't come to the doctor to be judged or to feel bad about themselves. They come to the doctor because they want help. And I think keeping that in mind is something that helps in one's approach to interacting with others.
I think that goes into play too, because I've heard from so many patients who may be overweight, and the common thing is, well, you know what, go exercise, eat better, lose weight. that'll fix the problem. And they're dismissed. And I find that a lot with, women of color, especially. How do you educate people, even if that is the answer in many cases, it's the approach. What would you like future physicians to keep in mind about the approach of handling these types of conversations?
Couple of things. One is, I think, recognizing that obesity is an illness. So hypertension, diabetes, alcohol use disorder, those are diseases. And so it's not just a behavior. Sometimes behavior is adequate, but sometimes, like, if you have asthma and somebody says like, oh, we'll just try harder to breathe, that's not going to be effective. So I think that one part of it is recognizing that this isn't some deficit on the part of the person. I think the other part is asking permission of, like, is this something that you want to talk about? Is this something that you're okay talking about? And then asking the patient, what are 2 small things that you think you can do to improve your health? But again, people have been so shamed about their weight. Like, they could stub their toe and people say like, oh, it's because you're overweight. Like, I don't think that invokes a trusting therapeutic relationship. And so I think all those things help.
All right, another question. You received an undergraduate degree in history. How do you think humanities education can help in the journey toward equity?
You mentioned earlier about how people can be really smart. There's something about learning about people's experiences, the things that people don't say, how you read between the lines, that I think that's really helpful, and being able to talk about lots of different things. So I don't think, I think many of the people on the phone are already in medical school, but I think that there's a richness that people can have outside of science. And so I think nurturing that. And as far as the health equity piece, my daughter is really into history. And so being able to tie historical things to current things helps us to have a different perspective, so that we can approach things with creativity, but also not get discouraged that we continue to have certain problems.
Okay. This person asks, you served wonderfully on a panel years ago at NEOMED's anti-racism workshop, the physician-patient perspective. As hate across the nation has seemingly become worse, has healthcare mirrored the nation's decline?
So I sometimes tell people that the organization is a microcosm of the world, right? So we have 77,000 caregivers, what we call employees. So I think that there's some of that, but I think that one of the things that's really great is that it's like I was saying, everybody's welcome, but not all behavior is welcome. And so we have gotten to the point where if somebody is saying something that's hurtful and hateful in response to something that's on the internet, then those comments are taken down. Their manager is, contacted so they can have a conversation with the person. I think that when I think about healthcare and how it's being impacted by a lot of policies. So we have Florida, and so there's some laws in place that if somebody's an immigrant, then like that has to be reported. And then you have a lot of very politicized views about gender affirming care. And so I think that we continue to provide gender affirming care. I think a lot of the information that's out there about gender affirming care is not accurate. There's no place in this country where a minor can get surgery to change their physical appearance. And so I think holding strong to our convictions that everybody needs to have science-based care is important. And so I think that there's the balance between the care that we provide and then who's in the organization and what's allowed to sort of be said and done are things that we balance well. But definitely there, this isn't my home state of California, for example.
I would love to listen to what you have to say regarding politics and healthcare, but I think we would be here for another week or so. We're running low on questions. If anybody else has, we still have a few minutes left. If anyone else has any questions, please do put them in the Q&A section. And you know, you had mentioned earlier about culturally appropriate care. You'd mentioned Ramadan. Are there any other things that these future physicians can learn relating to cultural based care that the Cleveland Clinic is doing, or maybe you would like to see the Cleveland Clinic do more of?
Yeah, we have a couple of our facilities have teaching kitchens. And so helping people to modify their traditional recipes, I think, is something that's really powerful. I think that I have a patient that has diabetes and high blood pressure and chronic kidney disease who is from a West African country. And so it's not really reasonable to like tell her like, okay, cut out rice, right? Like, and so I think that again, working with people, they are expert, but like sort of like throwing out options, I think it is something that's helpful, and recognizing, okay, well, you really like rice, but is there something else that like you might remove from what you're eating, I think is really important. The other thing is that I have Muslim patients who so they don't take gelatin. Well, I can't keep track of all the medications that have gelatin in them, right? But if I put in the chart that they have an allergy to gelatin, then it's going to pop up when I try to order a medication that contains gelatin. So I think that those things are helpful. I think just recognizing like being open and asking questions, and you know, not everybody fasts for Ramadan. There might be parts of their life where they can't fast, and so having those conversations with people.
Are you seeing a difference in empathy exhibited by newer physicians from what you would have seen 25 years ago? And I'm going to add, why, if so, why do you think that is?
So I noticed that one of my favorite colleagues who recently retired had been on the line, and she's one of the most empathetic people that I know. And so I don't necessarily know that it's generational. I think that newer doctors tend to verbalize when they see something that's not right in a way that I didn't see even 10 years ago, as far as like not necessarily like cowing to hierarchy, but really speaking up for what's right, whether it's noticing where there are opportunities for social justice or whatever it is. And so I think that that's different. And I think that part of it is the lack of focus on hierarchy, right? Like my daughter I was talking about earlier, she calls my friends by their first names, and one of my friends is from the South and had a problem with that. And so, but I think that generally, like a lot of people are sort of much more familiar and willing to speak up if they see something that isn't right, regardless of somebody's status.
There seems to be an epidemic of violence against healthcare workers. While there are many causes, do you think a lack of cultural understanding between patients and clinicians plays a critical role?
I think that globally, we have suffered a lot of loss, particularly in the last 3 years. And I think that people are acting out in lots of different ways. There's a lot of anger. And so, and I also feel like there are patients that feel like the doctor's a safe space, right? Like they can like just sort of say or do anything because we're impervious to being heard. And so I think that there's that aspect, but I also think that like people are just really struggling. And so how do you make space for people to sort of acknowledge that life is sort of hard these days? And you know, whether it's food, whether it's housing, whether it's transportation, whether it's juggling all of their responsibilities, But I think that there's a lot of acting out, and I think that part of it is that people feel more free about saying strong opinions that maybe used to only be said in closed quarters and hushed tones. And I think that that also plays a role in sort of how people are acting out, whether it's threats against hospitals or physicians or whatever.
As a family physician, I'm curious, there has been so much health misinformation out there. I was just talking to a physician yesterday about a viral TikTok about putting castor oil in your eyes to relieve everything from dry eye to glaucoma to cataracts. How, as a physician, do you handle that when some of your patients, you talked about very strong opinions, some patients are coming in based, they just believe what they're seeing on the internet. And then you have to sort of give them the scientific facts and they question that. How do you deal with that?
My sister gave me a mug a few years ago for Christmas that says, don't confuse your Google search with my medical degree. I tend to ask them sort of, what I acknowledge that they've heard that. I'm trying to think back to the earlier part of the pandemic where there was a lot of discussion about vaccines and treatments, and sort of asking people like sort of what are their concerns, what are their goals for their health. I've found that there are people that are, and I was just talking to a friend about this the other day, there are people that are willing to use some substances because they aren't prescribed, whether they're herbals or whether they're illicit drugs, because they don't know what's in a prescribed medication. And so like some of it has to do with highlighting when what someone's saying doesn't seem consistent. I think that more than trying to sway people, to my point of view, is making sure that they understand the risk. So you were talking about the castor oil, like the risk of what they're doing. Oftentimes people come to me and they'll say, can I take such and such? And I'll, look it up on complementary and alternative medicines. And either I'll say like, okay, that should be fine, or like, I really don't think that that's a good idea because it can make your hypertension worse. So I think that using one's experience, but also helping people to know what's going to be harmful or not, and then planting the seed, recognizing that like you're not necessarily going to convey to somebody effectively that like they need to do something completely different, but making sure that they're not harming themselves and that you're leaving the door open to have those conversations.
A question from our viewers: does opioid abuse create further challenges to pursuing health equity?
I think that the literature has shown that doctors perceive that patients from different backgrounds experiencing pain differently, and tend to under-medicate certain groups. So there's that. I think we have a lot of bias, as individuals, and that extends to doctors. And so I think that, yes, if you think about sickle cell disease, if you think about any number of things, different cultures have different ways of expressing pain. And so if somebody's really stoic as they're expressing pain, then that might be more socially acceptable to a doctor as opposed to if somebody's like sort of more emotive in expressing their pain. And so I think that we have to be mindful of our biases for taking care of people.
Okay, we're just about out of time, and I'm going to ask you for your final pearls of wisdom for all of our students who are watching who have to leave for class soon. So what would you love to leave them with?
I would want to make sure that you each know that you are making the world better by your decision to go into medicine, that many of us who have achieved have had hurdles, and whether or not you have hurdles is not what determines what your success is, but if you persevere and reach out to others. And lastly, I think that being true to who you are, while also recognizing that everybody deserves respect and dignity and getting care, are the things that I would convey. Thank you.
One more question got in under the wire, so I'm going to ask this one because I want to know the answer too. If you could give any patient one question that they should ask their doctor, what would it be?
Are you willing to partner with me for my health?
And that is the answer I was wondering if we were going to get. That's amazing. Thank you so much for your insight, Dr. Cobb. As always, this is a very informative session, and I'm going to hand it back over to President Langell.
Thank you very much. Dr. Cobb, truly inspirational. We appreciate your insightful words. And thank you for all that you do in making this world a better place. Monica, thank you as always for your expert moderation. We really are fortunate to have you involved in the VITALS series. I ask that all of you please join us next month on November 2nd, when our own Dr. Amy Acton will join us. Dr. Acton is a graduate of Northeast Ohio Medical University, and I think all of you know her from the great work she did in public health, leading Ohio through the initial throes of the pandemic. Dr. Acton is currently teaming up with WKYC on a new series called Hope, Healing, and Health. Until November 2nd, please stay engaged because it's leaders like you that make a difference for our communities and for our patients.
This is VITALS, Visionary Health Leadership in Action.